Hey everyone, welcome back to Curious Medic, your go-to channel for high-yield orthopedics that actually makes sense. Today we are tackling one of the most foundational topics in orthopedic surgery, fractures. And before you think, oh, I already know what a fracture is, hold on. Because by the end of this video, you'll not only understand the basic definition, but also the different types, how they heal, what goes wrong during healing, and exactly how we manage each one. From pathological fractures to stress fractures, from non-union to bone grafting, from traction techniques to ORIF, it's all here. This video is built for two groups, MBBS students who need a strong clinical foundation and PG and residency aspirants who need every MCQ-worthy detail locked in. So stick around, there's something for everyone. Let's get started. Let's begin with the basics. What exactly do we mean when we say a bone is fractured? A fracture is simply a break in the continuity of the cortex of a bone. The moment that cortical continuity is disrupted, whether completely or partially, you have a fracture. One quick notation tip. In orthopedics, the hash symbol, or pound sign, is used to denote a fracture. So when you see hash femur written in case notes by a surgeon, they're not hashtagging their lunch. That's a femur fracture. Now that we know what a fracture is, the next question is, how do you actually diagnose one? There are two routes to diagnosis: clinical diagnosis and radiological diagnosis. X-ray diagnosis is straightforward. You see a break in the bone, you've made your call. But what really matters is making the diagnosis clinically before the X-ray does the talking for you. Let's talk about the signs of a fracture. The first sign is abnormal mobility. This is the pathognomonic sign, meaning movement at a site where movement is not supposed to occur. The second sign is tenderness. This is the most consistent sign, present in all fracture types, including incomplete fractures. The third sign is crepitus. This is considered historical only. It's the grating sensation of rough fracture ends rubbing together. Now let's understand the logic here. The body only moves at joints. Your elbow flexes, your knee bends. That's normal. But if the midshaft of the tibia starts moving on its own, that's not a party trick. That's a fracture. That midshaft movement, where movement should never occur, is called abnormal mobility, and it is the pathognomonic sign of a fracture. Crepitus, the scraping sensation caused by serrated fracture ends rubbing against each other, was historically considered pathognomonic. Today, it is not something we test for. It's painful, unnecessary, and an X-ray makes it completely redundant. The only time crepitus matters in your exam is if abnormal mobility is absent from the options. Then crepitus is your fallback. Why is tenderness the most consistent sign? Because not all fractures are complete. Stress fractures and greenstick fractures don't break the bone entirely, so you may not get abnormal mobility. But whenever there is a cortical breach, pressing on it will hurt. Every single time. That's why tenderness wins on consistency. Once you can recognize a fracture, the natural next question is, why does it happen in the first place? Fractures occur due to two broad categories. The first is significant trauma, high-velocity injuries such as road traffic accidents, falls from height, or a direct blow. The second is insignificant or trivial trauma, things like daily activities, minor falls, or repetitive loading. This second category splits into two important subtypes. Stress fractures occur when normal bone is subjected to abnormal or repetitive force. Pathological fractures occur when abnormal bone is subjected to normal force. Here's an MCQ pearl to remember. The key to distinguishing stress fractures from pathological fractures is the bone status, not the force. Abnormal bone means pathological. Abnormal force means stress. Now that we've covered why fractures happen, let's dig into how they actually look, the different patterns a traumatic fracture can take. Based on the pattern of the fracture line, traumatic fractures are classified as follows. A transverse fracture has a fracture line perpendicular to the long axis of the bone, and it's caused by a tension force or direct trauma. An oblique fracture has a fracture line that runs diagonally across the bone, caused by a compression force or axial loading. A spiral fracture has a fracture line that winds around the bone like a corkscrew, caused by a twisting or rotational force. A butterfly fragment is a wedge-shaped fragment on the tension side of the bone, caused by a bending force. A comminuted fracture is when the bone shatters into multiple fragments, caused by direct trauma or a crush injury. A segmental fracture has two fracture lines that divide the bone into distinct segments, caused by high-energy trauma. An avulsion fracture occurs when a tendon or ligament pulls off a fragment of bone, caused by a strong muscular contraction. Now let's talk about avulsion fractures as a special category. Avulsion fractures occur when a tendon's pull is powerful enough to wrench a piece of bone away from its attachment. There are two classic examples. The first is a patella fracture. The quadriceps tendon contracts violently and avulses the upper pole of the patella. The result is a transverse fracture with the proximal fragment pulled superiorly. The second is an olecranon fracture. The triceps muscle inserts at the tip of the olecranon. A powerful triceps contraction avulses that tip, causing an avulsion fracture at the elbow. These two fractures are important not just as avulsion examples, but also because their treatment is unique, and that's covered later in the section on tension band wiring. We touched on abnormal bone briefly while talking about causes. Now let's go deeper into pathological fractures specifically. A pathological fracture occurs when an underlying disease has weakened the bone, and the fracture occurs with minimal or trivial force. Think of it this way. If a person fractures their femur just by getting out of a chair, the bone itself must have been abnormal. Something took away its structural integrity. Let's look at the common causes of pathological fractures. The most common cause in the elderly is osteoporosis. Other causes include bone metastases, with lung, breast, kidney, thyroid, and prostate being the classic primary cancers, primary bone tumors, Paget's disease, osteogenesis imperfecta, and radiation-induced bone weakening. Here's a clinical clue. The hallmark of a pathological fracture is pain before the fracture. The patient often describes a pre-existing dull ache at the site that suddenly gives way with a snap during a trivial activity. Now, the treatment principle. Treat both the fracture and the underlying cause. If it's osteoporosis, start bisphosphonates. If it's a metastasis, address the primary tumor and use supportive fixation for the fracture. On the flip side of pathological fractures, we have stress fractures, where the bone itself is completely normal. A stress fracture is the opposite situation. The bone is perfectly normal, but it is subjected to repetitive, abnormal loading over a period of time, causing the bone to gradually develop a fatigue crack. Who gets stress fractures? Military recruits, who experience a sudden shift to intense drill training. Dancers, due to repetitive footwork leading up to performances. Marathon runners and trekkers, and interns in their first weeks of hospital rounds. Yes, really. The common thread? A sudden increase in the intensity or frequency of a physical activity. Now let's look at the clinical features. Pain typically appears after activity. This is the opposite of pathological fractures, where pain occurs before the fracture. There is point tenderness. The patient can pinpoint the exact spot with a single finger. And lower limb bones are far more affected than upper limb bones, because weight-bearing is the mechanism. Let's talk about investigations. If a single stress fracture is suspected, the investigation of choice is an MRI. If multiple stress fractures are suspected, the investigation of choice is a bone scan, also called radionuclide scintigraphy. Here's a key point. X-rays are usually negative for the first 2 to 3 weeks. The fracture is simply too subtle to show up early. And finally, treatment. Rest and immobilization. Period. Since stress is the cause, removing the stress resolves the problem. Stress fractures come with a whole set of eponyms that examiners love, so let's run through the named ones. Orthopedics loves its eponyms. Here are the high-yield named stress fractures. First, the march fracture. Named after soldiers training for military marches and parades. All that repetitive foot stomping leads to a stress fracture of the second metatarsal, which is more common, or the third metatarsal, specifically at the neck. The neck is the most widely accepted answer for exams, though the shaft is also acceptable. Next, the runner's fracture. This is a stress fracture of the distal fibula seen in marathon runners. The name gives it away. Remember, runners, fibula. Now, the Jones fracture. Named after Sir Robert Jones, the father of modern orthopedics, who first described it. This is a fracture at the base of the fifth metatarsal, specifically zone 2, the zone that lies at the articulation between the fourth and fifth metatarsals. Let's break down the zones. Zone 1, the most proximal zone, is a pseudo-Jones or avulsion fracture, and it is less concerning. Zone 2 is the true Jones fracture, and it carries a high risk of non-union. Zone 3, the most distal zone, is a stress fracture of the diaphysis, and it is less commonly asked. Why does Zone 2 go into non-union? It sits in a vascular watershed zone. The proximal and distal blood supplies both converge toward it, but neither reliably supplies it. This means any fracture here is at constant risk of avascular non-union. Staying with athletes and runners for a moment, there are two more conditions that often get confused with stress fractures. Two more conditions seen in athletes that are important for your exam. First, Shin splints, also known as medial tibial stress syndrome. Who gets it? Marathon runners and trekkers. The mechanism: repeated muscle contraction leads to periostitis, inflammation of the periosteum, of the anteromedial tibial cortex. The symptom: pain along the anteromedial aspect of the leg that appears after activity. The X-ray is normal, there's no fracture line, and its technical name is medial tibial stress syndrome. Next, popliteal entrapment syndrome. This involves a congenital anomaly. The popliteal artery passes through the gastrocnemius muscle instead of beside it. Who gets it? Athletes with hypertrophied gastrocnemius muscles. The mechanism: during exercise, the hypertrophied gastrocnemius compresses the popliteal artery, leading to distal ischemia. The symptom: pain in the posterior aspect, the calf, during activity. And the X-ray is normal. Here's an MCQ distinction to remember. Anterior medial leg pain after activity equals shin splints. Posterior calf pain after activity equals popliteal entrapment syndrome. The X-ray is normal in both. Now that we've covered the different types of fractures, let's shift gears and talk about what happens after a fracture occurs, the healing process. When a bone breaks, the healing process is orderly, predictable, and, for exam purposes, beautifully structured. There are two types of fracture healing. The first is primary, or direct, healing. This occurs only when fracture ends are held with absolute rigidity, meaning zero movement. The bone tunnels directly across the fracture gap without forming a callus. This is rare in clinical practice. The second is secondary, or indirect, healing. This is the more common type. It requires only relative stability, with minimal micromovement. Healing occurs via callus formation on the outside of the fracture, bridging the gap. This is what we see in most clinical scenarios. Now let's go through the 5 stages of secondary fracture healing. Stage 1 is hematoma formation, which takes 2 to 3 days. The fracture tears the nutrient artery, periosteum, and endosteum, causing bleeding and a hematoma at the fracture site. This hematoma releases chemotactic factors that recruit fibroblasts. Stage 2 is the granulation, or inflammatory, stage, which takes 2 to 3 weeks. Fibroblasts migrate in and form a fibrous meshwork between the fracture fragments. This is classic granulation tissue. Stage 3 is the callus stage, also called the soft callus stage, which takes 2 to 3 months. Fibroblasts mature into osteoblasts, which produce osteoid, a cartilaginous and collagenous meshwork that bridges the gap, with low mineral content. Stage 4 is the consolidation stage, also called the hard callus stage, which takes 2 to 3 years. The soft callus becomes heavily mineralized, forming woven bone. This is the stage of clinical union. The fracture no longer moves on examination. Stage 5 is remodeling, which takes 3 or more years. Disorganized woven bone is replaced by ordered lamellar bone. The medullary canal is restored, and the periosteum and endosteum return to normal architecture. Now let's go through some high-yield MCQ facts from these healing stages. The first stage of fracture healing is hematoma formation. The last stage of fracture healing is remodeling. The earliest stage visible on X-ray is the callus, at around 3 weeks. The earliest stage of clinical union is consolidation, at around 3 months. The minimum time before implant removal is 2 years, and the time for bone to return to completely normal architecture is 3 or more years. So why does callus appear on X-ray at 3 weeks? Because the granulation stage lasts 2 to 3 weeks, and only after that does the mineralized callus begin to form and become radiologically visible. Healing doesn't always go according to plan, so let's look at what happens when this process goes wrong. First, delayed union. The fracture is healing, but slowly. On serial X-rays taken a few weeks apart, you can see callus progressing, but the bone hasn't united by 6 months. The key point: callus is present and is advancing, just at a snail's pace. Next, non-union. Healing has come to a complete stop. By 9 months, if there is no evidence of progressive healing, the fracture is declared a non-union. The fracture line remains clearly visible on X-ray. Here are the characteristics common to all non-unions on X-ray. The fracture line is still visible. The fracture ends are smooth and sclerotic, meaning denser or wider than normal bone, which is a sign of chronicity. And there is no bridging callus. Now let's compare hypertrophic and atrophic non-union. In hypertrophic non-union, callus is present. It's exuberant, but not bridging. The bone biology is healthy. The bone wants to unite. The underlying problem is improper immobilization, and the treatment is correcting the immobilization only. In atrophic non-union, there is no callus whatsoever. The bone biology is unhealthy. The bone is not even attempting to heal. The underlying problem is bone ischemia or poor biology, and the treatment is immobilization plus bone grafting. Here's the clinical bottom line. When someone says non-union without a qualifier, they usually mean atrophic non-union, because that's the one that requires active intervention, namely bone grafting. Now, the most common cause of non-union: improper immobilization. If the fracture is allowed to move before the callus bridges, the fragile bridging tissue tears repeatedly, and healing stalls. Other contributing factors include smoking, extreme age, open or contaminated fractures, interposed soft tissue, bone ischemia, and inadequate reduction. Finally, let's look at bones prone to non-union versus malunion. Bones prone to non-union include the lower third of the tibia, the most common, the lateral condyle of the humerus, the scaphoid, the neck of the femur, and the neck of the talus. Bones prone to malunion include the clavicle, the most common, the supracondylar humerus, Cole's fracture, and the intertrochanteric femur. Here's an exam trick. These two lists rarely overlap. A bone prone to non-union is unlikely to malunite, and vice versa. Use this to eliminate options. When healing fails completely, that's atrophic non-union. The fix usually involves bone grafting, so let's break that down. Bone graft is the treatment for atrophic non-union. The standard source of autologous, or self-derived, bone graft is the iliac crest. Let's go through the 3 properties of an ideal bone graft. The first property is osteogenesis. This means the graft itself produces new bone via the osteoblasts it carries. Can this be replicated artificially? No, it requires living osteoblasts. The second property is osteoconduction. This means the graft acts as a scaffold or canvas over which new bone and blood vessels grow. Can this be replicated artificially? Yes, using materials like calcium phosphate, calcium sulfate, or PMMA crystals. The third property is osteoinduction. This means the graft releases signals that stimulate the host's surrounding tissues to form bone. Can this be replicated artificially? Yes, using recombinant bone morphogenetic proteins, or BMPs. An autologous iliac crest graft has all 3 properties, making it the gold standard. Artificial substitutes can replicate osteoconduction and osteoinduction, but never true osteogenesis. Here's a mnemonic: G, I, C, like a dental filling that fixes bone. G is for genesis, it grows bone itself. I is for induction, it induces neighboring tissue to grow bone. C is for conduction, it acts as a canvas for bone to grow on. With the biology out of the way, let's move into the practical side of things, how we actually manage a fracture, starting with the basic algorithm and terminology. Let's start with the key terms you must know. Displacement is the movement of the distal fragment away from its normal anatomical position. The proximal part is assumed to still be attached to the body. Reduction is restoring the displaced fracture back to its anatomical position. Traction is the pulling force applied to counteract the displacing muscular force. Countertraction is the opposing force applied at the same time to prevent the patient from being dragged toward you. Fixation is any device or method that keeps the fracture in its reduced position until healing is complete. Now, why do fractures displace? There are 2 reasons. The first is the energy of the injury itself. The second is muscular pull. Muscles attached near the fracture pull the distal fragment away. So when reducing a fracture, the traction force must be greater than the displacing muscular force. Let's look at the methods of traction. Manual traction is pulled by hand. It's non-invasive and provides a mild amount of force. Skin traction, also called Buck's traction, involves an adhesive bandage applied to the skin, which is then pulled. It's non-invasive and provides a mild to moderate force, up to about 5 kilograms. Skeletal traction involves a pin inserted through the bone, which is then pulled via a baller stirrup. It's invasive and provides a moderate to high force, between 10 and 20 kilograms. Now let's talk about skeletal traction pins. The Steinman pin is smooth throughout and is used for normal, healthy adult bone, for tibial or femoral traction. The Denham pin is threaded in the center and is used for osteoporotic or cancellous bone and also for calcaneal traction. Let's discuss the upper tibial pin traction landmark. The entry point is 2.5 centimeters below and behind the tibial tubercle, entering from the lateral side and exiting on the medial side. Here's a complication to remember: pin tract infection. The organism is Staphylococcus aureus. Also, a ring sequestrum can form around the pin entry and exit sites if not properly cared for. Applying traction needs equipment, so let's look at the splints and traction devices used to put it into practice. First, Thomas's splint, invented by H.O. Thomas, the father of British orthopedics. Note, the father of orthopedics overall is Nicholas Andre, and the father of modern orthopedics is Sir Robert Jones. It was originally invented for his wife's tuberculous knee. It is currently used for femur fractures and other lower limb fractures. The design: a ring that sits at the perineum or ischium, plus 2 side rods extending distally. The mechanism: the traction rope is tied to the distal end of the splint. The ring provides counter-traction against the perineum. Both traction and counter-traction are built into one device. The type is a fixed traction device. It makes the patient mobile, meaning the fracture stays reduced while the patient is transported. And it was historically invaluable in wartime casualty management. Next, the Böhler-Brown splint, invented by doctors Böhler and Brown. It is used for femur and tibia fractures. The choice depends on which pulley is selected. The design: a splint with 3 pulleys. Let's go through each pulley. Pulley A applies force in line with the tibial axis and is indicated for tibia fractures. Pulley B applies force along the femoral axis and is indicated for femur fractures. Pulley C keeps the foot in a neutral position and is indicated to prevent foot drop. Now, the counter-traction mechanism. The foot end of the bed is elevated, raised on bricks, so the body slides by gravity, and the body's weight provides the counter-traction. The type is a sliding or balanced traction device. The disadvantage: the patient cannot be moved without moving the entire bed. Russell's traction is another balanced or sliding traction device, specifically used for intertrochanteric femur fractures. Once traction has done its job and the fracture is ready to be put back into position, you need a reduction technique. First, closed reduction. The fracture is reduced without surgically opening the fracture site. It's done by palpation, feel, and confirmation under X-ray or an image intensifier, also called a C-arm. It gives an acceptable, but not perfect, reduction. It is suitable for extra-articular fractures. Next, open reduction. The fracture site is surgically incised, and the fracture is visualized directly. Fragments are reduced under direct vision and fixed internally. It gives an accurate and perfect reduction, and it is mandatory for intra-articular fractures. Now let's compare intra-articular and extra-articular fractures. By definition, an intra-articular fracture has a fracture line that passes through the joint surface. An extra-articular fracture has a fracture line outside the joint. In terms of reduction required, for intra-articular fractures, the reduction must be perfect or anatomic. A step off in the joint surface leads to arthritis. For extra-articular fractures, an acceptable reduction is fine. In terms of preferred reduction technique, for intra-articular fractures, open reduction is preferred. For extra-articular fractures, closed reduction is usually adequate. Putting reduction and fixation together, here's the definitive management algorithm that ties everything up. Once you understand open versus closed reduction, here is the exam-critical treatment algorithm. For all intra-articular fractures, the treatment is ORIF with plates. That's open reduction and internal fixation. Since perfect reduction is needed, you must open the fracture site, giving you open reduction. And since you're already inside, You fix it internally, giving you internal fixation with plates. For upper limb long bone fractures of the shaft, the treatment is also ORIF with plates. This applies to the proximal humerus, which is intra-articular, the distal humerus, which is intra-articular, the shaft of the humerus, the shaft of the radius, the shaft of the ulna, and the distal radius, which is intra-articular. All of these are treated with ORIF using plates. For lower limb long bone shaft fractures, the treatment is CRIF with an IM nail, that's closed reduction internal fixation with an intramedullary interlocking nail, or rod. This applies specifically to the shaft of the femur, which is treated with CRIF using an intramedullary interlocking nail, or rod. However, the distal femur, which is intra-articular, is treated with ORIF using plates. Similarly, the proximal tibia, which is intra-articular, and the distal tibia, which is intra-articular, are both treated with ORIF using plates. So why is CRIF used for the femur shaft? The femur shaft is not an intra-articular fracture, so an acceptable reduction is fine. An intramedullary nail is inserted without opening the fracture site, hence closed reduction, and confirmed under an image intensifier, or C-arm, in the operating theater. The nail is then interlocked with screws to prevent rotation. And here's an exception to keep in mind. The shafts of the radius and ulna are extra-articular, but because the forearm requires near-perfect rotational alignment to function properly, ORIF with plates is the preferred option anyway. There's one special situation the standard algorithm doesn't fully cover: avulsion fractures with a strong muscle pulling on the fragment, and that's where tension band wiring comes in. When an avulsion fracture involves a strong muscular force constantly pulling the fragment away, a simple plate or plaster cast will not hold. Even if you reduce the fracture, the muscle will just pull it apart again. The solution is tension band wiring, or TBW, a technique that converts the distracting, or pulling apart, force into a compressive, or pushing together, force, dramatically improving stability. Where is tension band wiring used? For the patella, the muscle pulling the fragment away is the quadriceps. The rationale for tension band wiring is a transverse avulsion with a strong superior pull. For the olecranon, the muscle pulling the fragment away is the triceps. The rationale for tension band wiring is an avulsion of the olecranon tip with a strong proximal pull. For both of these fractures, the technique is open reduction plus internal fixation plus tension band wiring, written as ORIF plus TBW. Finally, once a fracture has been reduced and fixed, it often needs to be immobilized in plaster. So let's compare a slab and a cast. First, the chemistry of plaster of Paris, or POP calcium sulfate hemihydrate, combined with water, forms calcium sulfate dihydrate. It sets, hardens, and generates heat. Now, the slab, also called a splint. Plaster is applied to only part of the circumference. This leaves room for swelling. It is used in acute injuries to prevent compartment syndrome, and it is later converted to a full cast once swelling subsides. Next, the cast. Plaster is applied circumferentially all around the limb. It is more rigid, giving better immobilization, but it is not used in acute settings due to the risk of compartment syndrome. Button if this helped. Subscribe to Curious Medic for more high-yield orthopedics content, and drop your questions in the comments. I'll see you in the next video.